It's a 66 years old male with a side branch IPMN since 2 years ago, but no symptoms. Now you ask for a follow-up.
Here I am in the body of the pancreas. I can see the splenic vein, and I can go through the tail of the pancreas. Now I go back, and I see almost normal pancreas with some strands, white strands. And here I can see the duct and some dilatations of the all ducts. And I go in the direction of the head of the pancreas on the other dilatations, more little dilatations of side branched. And here we can see another image with more dilatations. And there is no sign of communication with the main duct. And here another one, bigger one. This lesion with a lot of septa inside. And it measures around 2 centimeters. So 1.9 to 10, 11. Okay. Perfect.
So do you believe that contrast-enhanced ultrasound would help us to give additional information regarding the septa and nodules? What is your impression?
I think that here we don't have nodules, but regarding the septa, yes, maybe we will have some enhanced. I think that it seems like a serocystic adenoma, this one, and we can use the contrast. We can.
I'd be interested to hear what your criteria, and I think a lot of people in the audience be interested for your criteria for considering a puncture of such a cyst.
Of
so
puncture?
When would you decide to puncture it? What things would make you do that?
The cyst is less than 3 centimeters and don't have nodule inside. So we don't. It's the first examination. We have a lot of little cystic lesion, and this lesion without this nodule, without alteration in the contours of the internal cyst. So I think that is not mandatory. The FNA here.
Okay, I switch to the
yes.
Ready for MS?
Yes, let's go.
Okay, we switch into the contrast mode.
Okay. So we switch to the contrast mode now.
We inject? No.
You have? Or you do?
No, not at this moment. Resolution?
Perfect. There is no enhancement. No enhancement.
But we didn't inject so far.
Jet?
Do you want to re-inject now?
Yes, thank you.
Okay, injection.
We start the injection.
And I start the film.
Michael, excuse me, can you ask the doctor if it's interesting doing Sulvisio in this case? Because maybe he wants to know if this is really a serocystic in a patient that has already a suspicion of IPMM of the second branch, and it would be important because this is the biggest one.
Okay.
So maybe if he does Sulvisio, and this is really an IPMM and not a cystic seroadenoma, then maybe a follow-up or therapeutic decision would be different. So could you ask him? Because maybe he can do it now. Especially if he's doing contracts and there's no enhancement. if it be a serous cystadenoma, you will expect an enhancement. And in this case, it's not having an enhancement, so it's going towards IPMN of secondary branch, and it's
Yes.
already 2 centimeters.
So we have a question from the audience. Did you hear the question from the audience or not?
Yes, I heard the question. Yes, no enhancement inside the
So the
lesion.
question is, so would you do NCLE, basically, needle-based confocal microscopy in this kind of lesion?
Okay, this lesion has 2 centimeters, and I think it's a little difficult to perform NCLA. I don't know if somebody performs in lesions less than 3 centimeters. Maybe I will have some difficulty to perform here. I don't know the experience of people here in the room. What do you think about little lesions with 2 centimeters to perform an NCLA?
But just for the academic
2
discussion,
centimeters, okay?
imagine this is 3 or 4. Imagine it was bigger than 2. Let's
Yes.
imagine it was 3. Would you do NCLE?
Yes, it's possible to do it. Yes. Here
But it's
we are
mainly
not
the-
sure.
We have to think about the pretest probability. That means the age of the patient, the comorbidity, and all that factors which might influence our solution. And we always try to get a definite diagnosis or recommendations without any invasive procedure if possible. So if it were a lesion larger than 3 centimeters, if we would have mural nodules larger than 5 to 10 millimeters, if they enhance and age and comorbidity is not contradictory to operation, we do not need to do any kind of additional workup before operation. And
Christoph,
But this
Christoph,
is 3
since you are
centimeter
the
lesion.
contrast-enhanced EUS expert, in this case, we performed a contrast-enhanced examination. How did it help you in this case?
Yeah, so first of all, we did color Doppler imaging. We were looking for macro vessels. We did not see macro vessels. Therefore, it's not a serous, microcystic, or oligocystic pancreatic adenoma. It's out of the diagnosis. Second, we saw no nodules, but septa. We were interested if those septa show any kind of enhancement. Yes, we saw enhancement, individual bubbles in the septa, but no, let's say, neoplastic vessels. And then we have to take into account the whole story, the age of the patient, comorbidity, and so on. So it's a neoplastic cystic lesion, we are sure. It's a mucinous cystic neoplastic lesion without the predominant risk factors.
I think it won't change management of the patients if we know if we have a diagnosis of cirrhosis of IPMN, because we have IPMN
In other PMN.
in the other part of the pancreas.
Yes.
So we needn't really diagnose this.
That's totally true. But
It's serous.
A lot of IPMN
so
in
the
the rest of the
diagnosis
body.
of multiloculated IPMN is somewhat
You are sure that's IPMN?
yes.
No, there are other IPMN. Don't change everything.
So it's no serocystic adenoma because there are no macrovessels. First. Second, it's multiloculated. We see individual septa, and those septa are perfused. Not very much, but they are. It's no pseudocyst, it's no serous pancreatic adenoma. It's a mucinous lesion from the pretest probability. Right now, we have only to judge if that is benign or malignant. We have the size, we have the perfusion of the septa, no mural nodules. So we have up to now a pretty low probability of malignant transformation. And depending on age and comorbidity, if we would be young and if we would look for more reasons, I would go that way to take a puncture and to get out CEA and lipase in that specific case. If he is old and if he has some sort of comorbidity, we could leave it. It depends. It's a balancing decision making.
No, because if you have a low lipase, a low
I have
CEA,
a question for Dr. Giovannini.
is a serous. Huh?
We have a
Yes,
question
but
from the
if
audience.
it's
yeah,
high,
we'd like to say.
there are other cystic
Dr.
lesions.
Giovannini,
It's macular.
Yes.
Even the
Dr.
experts
Giovannini, do you
Yeah.
hear us?
have
Yeah,
problems
yeah,
here
yeah,
to
I hear
decide.
you. I hear you.
Yeah, Dr. Giovannini, I have a question for you. Do you
Yes.
think in this case, now that you're thinking more in IPMN, but I see that you still have the doubt from cystic adenoma. Do you think confocal will help us definitely to know if it's,
Yes,
if it's
yes,
definitely
confocal
IPMN?
could
And
be.
then do you think,
Yes, but
do
for
you
me-
think
for me-
confocal
yes.
could help us
Yes.
in benign and malignant IPMN? Do you think confocal could help us also to differentiate benign from malignant IPMN?
No, I think for me, the confocal is not the first line examination. The first line is to do aspiration with to know the CEA and the lipase. If after this first and the cytology, if after this first evaluation the cyst is still undetermined, yes, I perform the confocal. But the confocal is not easy to differentiate. In case of IPMN, benign and malignant, because as you know, the malignant lesion can be focused on one area of the cyst. You can have a skip lesion. If you are lucky, you can find sometime a very black amount of umps of malignant, but it's not easy. It's not easy to conclude to a malignant IPMN with the confocal. But you can conclude is a IPMN or to conclude it's a serous cystadenoma. This is quite possible with the confocal microscopy, but only in the indeterminate cyst. Because if you
So
perform...
you're going to perform an aspiration?
Yes, because
of
if you do the aspiration,
Okay.
if the CEA is low, if the lipase is low, if the cytology show no mucin, I think it's... the differential diagnosis is between IPMN and serous cyst. It's always the same problem.
But this will change only the follow-up of the patients. If
4
you-
minutes, yeah.
It had other EPMN in the pancreas.
There is other cystic
Other
lesion?
cyst lesions.
Many
It's
are.
There are the-
This is also an argument for
Yes.
for IPMN.
That was the reason why we have been pretty sure. And second was the reason of the
Okay,
the
now
vessels.
if there is multiple lesion,
Yeah.
this definitively
More than
in
five.
is
More than
definitive.
five
Yes.
at different.
You-
Okay.
So
Okay, no puncture and just follow up. There is no malignance aspect of the lesion. Okay, it's just a follow up for this. What kind of follow up? You can
6
remove the
months.
scope. You have 4 minutes.
6
4
months.
minutes to discuss about the
No.
follow up.
Yeah.
3 minutes.
To be close with the follow-up. I have 6 months follow-up with another US.
We have another US.
US.
6 months.
6 months.
What is your
2
follow-up?
centimeters.
1
A lot of.
1 year. And you? 1 year. And
six-
you? No.
MRI. 6 months
You know-
MRI.
you know-
6 months US.
Can you ask in the audience what kind of follow up?
The recommendation is basically by at least European experts and the international experts from 2013 and 2012. This is benign lesion. Based on everything you said, you can follow using an MRCP. You don't even have to follow using an EUS.
Agree.
And the follow-up period is 3 to 6 months. This is the consensus. It's not
The
evidence-based
Sendai
consensus.
and the
Consensus-based.
Furukawa consensus is for me. I don't use this consensus because it's impossible to understand something.
If we would use
3 months,
this,
3 months follow up is
it's
impossible.
stupid. Nothing will happen in 3
No,
months.
no.
And be aware, if we use for all that patients in our daily routine a 3 months follow
No,
up,
It's too much.
No.
I
This-
would have to concentrate on all
this
that
patient
lesions. I couldn't
should
do
have
anything
MRCP
else. So
in 1
that's
year.
far away from reality.